Thank you to everyone for joining. It's always a bit strange with these kind of events because I'm sat in a room talking to myself. Um, if anyone has any questions, put them in the chat, and Charlotte will hand them over to me or ask questions at the end. So I'm actually in the Cobalt Centre, so hopefully the technology is okay and the Wi-Fi is not going to crash halfway through. But if there's any problems with my volume or anything, again, let Charlotte know. So I'm a knee surgeon based in Cheltenham General, Gloucester Royal in the Trust, and also do private clinics here at the Cobalt and at the Cheltenham Nuffield as well. And my interests are basically everything in the knee, so knee arthroplasty, including revision knee surgery, and then a large amount of my practice is soft tissue knee injuries, and that's what I'm going to be focusing on tonight. And what I was going to try and do is talk about ACL injuries more from the surgeon's point of view, and really try and give a bit of background as to why we make the decisions that we do, and in particular which patients end up with an ACL reconstruction, and as people who may be seeing them as physiotherapists and other practitioners, sort of what the red flags and what to watch out for. So hopefully this isn't new, but I'm just starting with a slide of the anterior cruciate ligament. I think there's a fact that it's the bit of the body with the most publications on it, so it's very well studied. It's just a 3 centimeter length of rope coming off the lateral femoral condyle and then inserting on the anterior tibial spine. Of course, as well as the ACL, other ligaments in the knee can be injured at the same time or separately. And sat behind there, the posterior cruciate ligament, and then obviously the medial collateral ligament commonly injured as well, and occasionally the lateral collateral ligament posterolateral corner. But the other structure which is going to be key for the talk tonight is the meniscus in the knee as well. And that's very relevant for who has an ACL reconstruction and for timing of ACL reconstruction as well. So we'll talk about the meniscus a little bit later. In terms of the anterior cruciate ligament, obviously it's a very common injury. I've done an acute knee clinic today in Cheltenham General, an elective clinic, and I'm not sure how many patients I've seen with ACL injuries, but it's a fair number. In the US, there's 6 figures of ACL injuries every year, and it's affecting the youngest, most active members of society often. So those engaged in pivoting sports, so football, netball, skiing, rugby, etc. And of course, some people are more prone, and there's a lot at the moment about female footballers and ACL injuries as well. As an injury, it's often non-contact, and it can affect any age, including children. And I am involved in some work in injury prevention as well to try and decrease the risk of ACL rupture in children as well, which I can touch on a little bit later. So the overview of the talk is basically we're going to look at initial assessment. So the first contact people who are seeing a patient with a potential ACL injury. Then the big question really, which patient should have an ACL reconstruction? And I'm just going to highlight the sort of surgical rationale behind the decision for surgery. We'll also talk about the meniscus as well, how that affects the decision-making process and the different techniques that we're now using. I'll also talk about the different graft choices, as often this is something that patients like to discuss when they're seeing their physiotherapists. And I'm going to finish by talking about lateral extra-articular tenodesis, which is a technique that we're using more commonly in knee surgery. So it's just a bit of background about rationale for that and how that may change things around the time of surgery as well. So in terms of diagnosing an ACL injury, the key bits, as for anything in medicine, are always first of all taking a history, then examining the patient, and then looking at the X-ray and MRI findings. And often patients do things sometimes the wrong way around. and it's not uncommon for patients to come along with an MRI scan and say, I've torn my ACL. But the key thing really is, first of all, in terms of history, how it affects them, what they want to do as well. Also, it's important as well to sort of see how that adds up with the examination as well. And examining knee laxity is important, and putting all of that together to make a clinical decision. In terms of ACL injuries, unfortunately, they're often still missed when patients come to A&E. They can often be a fairly obvious injury, and patients will often describe a major injury, so the leg giving way. It tends to be significant that patients will come off from the activity and able to carry on. There tends to be a large effusion, and because there's blood going into the knee, the hemarthrosis tends to occur within a few hours after the injury, so an almost immediate swelling. And patients often complain that they've heard a pop or felt something at the time of injury as well. And this is a nice little table, which if I'm presenting talks to GPs or A&E, often bring out, and it's the limp index. And essentially, if of these four, if patients complain of two of them, you have to have a fairly high index of suspicion for an ACL injury. But it's a relatively easy mnemonic to remember. And just asking those four questions to a patient just lets you sort of focus in if there's been a significant injury. It's not always like that, and there are sometimes patients who present with sort of what sounds like more minor trauma and have torn their ACL as well. So it's not always clear cut, but a lot of the time just focusing in on like this is a very useful thing to do. So after the history, the next thing as a clinician to do is to examine the patient. In terms of a basic examination for a knee, if they're seen acutely, obviously patients may have a large effusion in the knee, which is often fairly obvious. And in terms of initial assessment, the range of movement is key as well. And one of the things which I'm interested in when I'm first assessing a patient is, can they get the knee straight? And there can be blocks to extension. And sometimes those can be due to physical reasons, other injuries in the knee, including the meniscus as well. There are obviously specific tests for the ACL. And again, we'll come back to biomechanics a bit later, but the ACL is really being assessed in two planes. One is in a front to back direction, which is for anterior posterior instability. In the picture here, someone's performing a test for that. And the two ways of doing it are, first of all, the AP draw, which is when the knee is brought up to 90 degrees, and it's an assessment of anterior tibial translation. If you're assessing at 90 degrees, of course, you've got to be careful as well that it's not a PCL injury and moving the other way. And similarly, Lachman's is a test of anterior draw. For me, I tend to perform Lachman's rather than an AP draw, and it's shown to be more sensitive as well. The key things really, if you're performing a Lachman's test, are to make sure that the femur is really stable. Making sure that the relative movement of the tibia and assessing the tibial tubercle rather than moving both bones at the same time. And if it is difficult to stabilize the femur just with your hand, then one way is just to put your knee underneath the femur, make sure it's really steady, and then try and get that AP movement. The other tip as well is also to examine the other knee as well, and just assess what the patient is like naturally and how much laxity they've got in the knee as well. The second test, which is specific for ACL injury, is the pivot shift or variations on that. And that's basically a test of rotational instability. And this is really key because when patients are struggling to return to sports, rather than being a problem in the AP plane, which can often be well controlled with, or better controlled with muscles, the rotational element is often more difficult to control as well. The pivot shift is quite a difficult test to perform on a patient when they're awake. And I'm lucky because I can examine patients when they're asleep. But if a patient has got an explosive pivot, that's certainly a good reason to perform an ACL reconstruction. In terms of initial assessment, there has been some fairly recent guidance, and this has been produced by BASC, the Knee Society, and I was involved at the time as Secretary of the Knee Society when this was produced. and it's also been produced with the BOA and BOSTA, which is the UK Sports Trauma Association. And I'm going to put that up just to sort of guide around initial assessment. One of the guidance is that if a patient has a significant hemarthrosis and has what appears to be significant injury, they should be assessed in an acute knee clinic, at least in the NHS setting, by a surgeon, a physiotherapist, or someone suitably trained. And ideally, they should be assessed within 2 weeks of presentation. And that's important to identify time-dependent injuries, such as some of the meniscal tears that may need to be repaired. This is something which we struggle with in the trust. And unfortunately, patients do sometimes wait longer than this and often have gone to see a physiotherapist or other practitioner privately in the meantime. The other thing which is really key is that from that clinic, there should be access for urgent imaging facilities. And we're lucky in Cheltenham that the Cobalt Centre is here, and that allows normally very rapid access and can get scans in a couple of days with a good report from musculoskeletal radiologists as well. An MRI is really the treatment of choice, or the modality of choice for diagnosing an ACL injury. We'll have a look at some pictures shortly about that. The other key thing which really affects what's going to happen subsequently to the patient is a documentation of other injuries. So for me as a surgeon, I'm very wary of if other multi-ligament injuries have occurred, injuries to PCL, posterolateral corner as well, which need to be treated, make this a much more serious injury. And the meniscus, again, is really key, because it's the meniscus longer term that's going to lead to osteoarthritis developing if it's not treated adequately. So that's why it's really important to identify meniscal injuries as soon as possible. And then the final part of that guidance, which we'll come back to, is that then a management plan should be made with the patient as well, and discussion of treatment options, which we'll come back to. And those treatment options can be, of course, non-operative and operative. This is really the crux of the matter, and why as surgeons we reconstruct the ACL, and it's for symptomatic instability. And patients often come early in post-injury and will complain of severe pain or swelling. And of course, that's not a reason for doing an ACL reconstruction. That's going to improve with time and non-operative management. But it's that giving way, which is really the key reason to reconstruct the ACL. Now, patients often will reach a position with non-operative treatment where they may well not have symptomatic instability day to day. But of course, it does depend on how they push the knee. And of course, trying to return to pivoting sports and do more leads to a greater chance of symptomatic instability as well. But essentially, that's an individual patient decision. Of course, non-operative treatment is always reasonable, and it's a good thing to do even if a patient is waiting for an ACL reconstruction. But there are some caveats to that around meniscal injuries as well. I'm just going to put up some images of patients who've torn their ACLs, just as some demonstration slides. Most of the time, patients who've been to A&E tend to get an X-ray of their knee if they've got a large hemarthrosis. Of course, it's important to rule out other things if you're seeing a patient for the first time, and if a patient can't weight bear through the knee, you have to be suspicious of a fracture. I've certainly in the last 3 months had a patient who came along with what sounded like an ACL injury, and when he had his MRI, there's nothing to see on the X-ray, but he did have an undisplaced tibial plateau fracture. And sometimes you will pick up tibial plateau fractures just on the plain films when you're not expecting them. So if a patient has significant injury, can't weight bear, it's something to bear in mind. And obviously a quick X-ray is easy to get. Assuming there's no fracture, the most likely thing we'll see, which will point to an ACL injury, are bony avulsions around the knee. So the image on will be the left of your screen. Is showing a C-gond fracture, and that's a small fragment of bone which is just avulsed from the lateral tibial plateau, just which you can see in the image, just sort of looks like it's sitting above the fibular head. And essentially, this is caused by a rotational injury of the knee, which occurs at the same time as an ACL rupture. And essentially, if you see a C-gond fragment, the chances of the patient having an ACL injury are really high. Sensitivity somewhere in the high 90s. So if you see that, essentially the patient's got an ACL injury. The other fragments which may be seen around the tibial spine, commonly we tend to see those in pediatric patients, where the ACL ligament tends to be stronger than the bone. So patients tend to pull off a bit of bone rather than rupture the ligament. So again, they're fairly obvious when you see them. The relevance of those, again, is they are time-dependent injuries. And essentially, if we're going to fix them back, and there's different ways of doing that, either with sutures or with wires, ideally we want to do that as soon as possible. Unfortunately, only last week I had to deal with one where it was 5 weeks down the line by the time he actually got into surgery. And essentially, if the fragment is displaced at that point, it's very hard to push it back into place and hold it. So tibial spine avulsion fractures, if you see those in particular in kids, they're ones really to get into the urgent system as soon as possible and not leave them too long. There's just an image here of a sagittal knee, which is showing a torn ACL. And if I have an MRI, I like to show patients the images, they see them themselves. And a lot of the time when patients have torn their ACL, it is fairly obvious on the MRIs, as the ACL is essentially a length of rope under tension, and it tends to be a femoral injury, so it tends to pull back, and it's fairly obvious when the fibers are sort of pulled back and slackened. Patients as well often get quite hung up about the words used to describe what's happened to the ACL, and patients will sometimes come along and say, "Is my ACL torn or ruptured?" I think it doesn't really matter what words you actually use for that, but the key bit of information is it working or not? Is it functional? So does the patient have that symptomatic instability or not? But whether it's described as ruptured or torn or other words, I think doesn't matter too much. The MRI is also useful as you can see other signs that there's been an ACL injury as well. And quite commonly, you can either see indentations in the femur, so this is a sulcus sign that you can see on the left, or patterns of bone bruising. And essentially, when a patient has an MRI scan, hopefully at that point the knee is in joint. But when you tear your ACL, you'll tend to dislocate or sublux your knee, and the knee moves out of joint. So what we can see is on the image there with the arrows, at some point in time, the femur has come off the back of the knee, hit the back of the lateral tibial plateau, and then come back again. And the bone bruising, the whiteness, which you can see in the MRI, is basically the imaging. That's a shadow of what's happened to the knee at that point in time. And essentially, if you see that pattern of bone bruising on an MRI, it almost inevitably means the patient has torn their ACL, because there's so much force that's gone through the ACL, it's very hard for it not to have ruptured. So if I'm looking at an MRI myself, rather than looking at the ACL first, I'll always scroll through and look for the bone marrow and the edema in the bone, as really that tells you what's happened before you've even looked at the ACL. There's often this confusion around the high-grade ACL sprain, and again, what that actually means. Sometimes when the ACL ruptures, it obviously doesn't disappear, and sometimes the fibers do try and stick down. So sometimes if I go in to do surgery, I'll see that the ACL is stuck back on the PCL. Sometimes you can get a sort of stretching out of the fibers without a clear, complete rupture. This is a report from the Cobalt, which is a good radiologist report. They've written high-grade tear ACL and then clinical assessment needed to assess functional integrity. So that's really the key thing. And again, it's not treating the scan. And to a degree, it doesn't really matter what the scan is showing, in that it has shown an ACL injury. But the key thing again is, does the patient have symptomatic instability? So are they complaining that the knee gives way? Is there a history before that suggesting the ACL has been ruptured? And of course, what does the knee feel like? So does it feel lax on examination? Is it giving way? And if all of those things fit together, so if there's a clear history, if they're complaining the knee's giving way, if the knee feels lax, but then you get this as a high-grade ACL sprain, you can fairly much conclude the ACL isn't really working. It's quite rare that it happens, but if I have still got reasonable doubts, and this will maybe happen kind of once a year, then the other thing to do is perform an arthroscopy, keyhole surgery, have a look inside and actually see what's happened to the ACL directly. And also, at the same time, I can examine the patient under anaesthetic as well. So it's not very commonly that it comes to that scenario, but it does happen once in a while. I'm going to move on to ACL surgical reconstruction itself. It is a common operation, so I've done 2 this week. And despite it being common and something as knee surgeons we do week in, week out, it's still a big operation. It's still an hour and a half surgery. With surgery always comes some risk. And of course, we do what we can to minimize them. But if a patient's unlucky and, for example, gets a deep infection, then that's a really devastating complication. That's months of antibiotics and further surgery and washouts. We worry about damasceners and blood vessels, bleeding, DVT, and then there's sort of post-operative things which can be problematic. Stiffness, of course, is one which can be an issue when people are rehabilitating knees as well. And the other thing I always tell patients as well is if you choose to have ACL surgery, it's a big recovery as well. We tend to say 9 months, but for a lot of people, it's up to 12 months before returning to sport. So it is a big investment of a patient's time. And particularly as well, if they're in a physical job, I tell them it may be up to 12 weeks off work as well. So again, it's a big thing for patients to go through. In terms of that question, who should have an ACL reconstruction? I've given some ideas so far, but really no sort of particular hard and fast rules. And the actual clinical evidence wasn't particularly, or isn't particularly great, as with many areas of orthopedics and surgery. This was an attempt to rectify that, and this was a study called the SNAP ACL trial, and it was run from University of Oxford, and it's been published in the Lancet, and it involved 29 centres around the country, including Gloucestershire NHS Trust. I was PI in the trust for this. And essentially what this study looked at was looking for patients with symptomatic instability, had an ACL injury, but didn't have meniscal pathology where they basically needed an operation. And they were then randomized either to surgery or to physiotherapy. So really it was a pragmatic real world trial. And one of the problems with doing this is there are so many different variables for the individual patients, what they want to do. And they're essentially assessed then with knee outcome scores at 18 months after. And essentially 316 patients were randomized. There was quite a bit of crossover between the groups. It was also quite a hard study to recruit for. And the reason for that is by the time patients come through to see a surgeon, often they did have fairly preconceived ideas. So they may already have made a decision they wanted surgery, so couldn't be involved, or other patients just decided they didn't want to have an operation at all. But the overall results were in favour of surgical outcome. I think that's probably not a particular surprise for this patient group, as these are patients who were all a couple of months down the line following an ACL injury and had symptomatic instability at that point. So they're obviously patients who were sort of developing problems, and those who were sort of okay and maybe were not having issues had already been filtered off as well. So it gives some evidence, but I don't think it necessarily helps with every patient sat in front of us in clinic. So going back again to who should actually have an ACL reconstruction and what factors to consider, as I said, there are many different factors. One, of course, is first of all, we actually have to confirm they got an ACL tear and have symptomatic instability. So unless those 2 criteria are met, there's obviously no clear reason to do an ACL reconstruction. And as I said, it's important to nail that down and make sure that patients aren't having an ACL reconstruction, for example, because they're in pain for some other reason as well. The other thing which may well drive a decision for surgery is the meniscus as well, and also if there's other ligament injuries as well, which of course may make the knee feel more unstable if there's significant injuries, for example, to posterolateral corner or PCL as well. This is actually from the NHS website, and this is their comments on it, which I think are very sensible. So the decision to have an ACL reconstruction depends on the extent of damage to the ACL, what else is damaged in the knee, and quality of life. And they suggest on that it also comes down to whether patients have an active lifestyle, whether they can get away without surgery as well, and then have a discussion about whether or not to have surgery. And I think that's overall very reasonable advice as to whether or not a patient should have their ACL reconstructed. The other factors which feed into that in terms of active lifestyle and what I'm interested in when I see a patient are what they do for a living. And sometimes, again, that can drive it. So I've had patients who are scaffolders and just don't like the idea of going up and down ladders, being on roofs with an unstable knee, which I think is entirely reasonable. Of course, some people, if they're professional athletes, so if I'm seeing a professional footballer, they're obviously not going to do particularly well unless they have an ACL reconstruction. And then for other people, it's the social activities and how much they want to do as well. A lot of patients will choose not to go back to pivoting sports after tearing their ACL and even after having an ACL reconstruction. And there's a big study in a Scandinavian country, and they found it's only about 40% of patients who end up having an ACL reconstruction. So end up returning to sport after an ACL reconstruction. So the numbers are probably lower than what we think. Age in itself isn't a barrier, and I spoke to a lady a couple of weeks ago who's 73, who torn her ACL 2 years before, and she wanted to have another discussion about ACL surgery. Obviously, as patients get older, often they're slowing down anyway. And if it's a patient in their 60s or 70s, the key bit of information really is that patient developing osteoarthritis of the knee? And of course, if they're reaching a point where they're developing osteoarthritis, they might be heading to that sort of area of knee replacements, etc., then reconstructing the ACL isn't a particularly sensible thing to do. But I've certainly have reconstructed patients in their 60s with an ACL tear who are active and wish to remain so. So a couple of examples of patients seen fairly recently. I had scans of the Cobalt. This is a girl who's 16. She's torn her ACL. She also has an associated meniscal injury. So she's got a medial meniscal tear as well. We know that she's going to be at increased risk of osteoarthritis if that's left. She also wants to be active. She wishes to return to sports, including netball and hockey. And so she's opted for an ACL reconstruction. And I think most people would think that's a fairly reasonable decision. This is a patient who's 55. She's again had a scan of the Cobalt. She's got a complete rupture of her ACL with no other associated injuries, so meniscus looks okay. She has done that skiing, and she's generally very active as well. She's in an active job and wishes to go back to skiing and doing other sports. And she opted for an ACL reconstruction. And that's one where I think it could be argued that she maybe would have got by with physiotherapy, but she'd already researched it and had made a decision, which again I think is reasonable. And she's now about couple of months post-op and is doing well. So these are again the guidance which I spoke about earlier, which is the BASC BOA guidance. A couple of points which are relevant is that all patients, of course, should have prehabilitation. In particular, knee movement is key. And of course, keeping muscle strong as you lose muscle strength very quickly. In terms of surgery, when it's considered, the knee in general, it's better to operate when it's quiet, but it's not an absolute no. And if there are other reasons to go in, for example, meniscal tears, it is okay to go in at that point, so we can go in earlier as well. And then really the other thing, again, which I'll come on to, is the meniscus. And most of the time, we tend to think it's better to reconstruct the meniscus and the ACL at the same time. Certainly for patients who have an isolated meniscal tear in an ACL deficient knee, there's a much higher chance of the meniscal repair failing. So really, if a meniscal repair has been done, it should really be done with the ACL. So in terms of the meniscus is obviously the shock absorber in the knee. It doesn't have a particularly great blood supply. The blood supply comes from the periphery rather than inside the knee. So essentially it can't heal up very well on its own. In the past, surgeons would quite happily remove the meniscus. A fair amount of patients I see in their 60s now have had complete meniscectomies years ago. But nowadays we're really quite aggressive at trying to fix the meniscus and repair it wherever possible. And it's really the meniscal surgery that early on dictates the post-op rehabilitation and limitations. And I've got some pictures here of a couple of different techniques which you might come across. One is the root repair, and that's the bottom left of the picture. And that's something I've had to do once this week already. And essentially, the meniscus is anchored at the front and the back with the roots. And if one of those tears off, then the whole meniscus is unstable. So nowadays, we're much more aggressive at trying to pull those back down and fix them. The relevance of that is if you're someone who's rehabilitating a ACL after, is they do need to be non-weight bearing for 6 weeks after. So that quite dramatically changes post-op rehab. Most of the time we can get away with these devices, which are the ones in the middle of the screen, which are the orange ones, and they're all inside devices. And essentially they push out 2 sutures, and they're easy to use and reliable. And then the other techniques are inside out, and this is an older technique, which is basically using open sutures, which is in the bottom of the picture. And really that's used where the meniscal tear is coming further forward, and it's hard to get with the all inside devices. And then finally, if there's a tear towards the front of the knee, sometimes the only way of fixing it is to make a little open incision and then put sutures through and tie them round. And that's rarer. And again, I've done that once in the last sort of couple of months, whereas the sort of using the fast fix inside out and a root repair would be something that's happening on a weekly basis. This is a patient who has got a meniscal root tear. So I'm just putting that up to see, as I think it's a relatively easy thing to see when you know what you're looking for. And this is a sagittal view of the knee. So what we're looking at here is the femur on top, tibia below. And because it's a cut view, the meniscus has been cut across, so that there should be a bit at the front and the back. And towards the front of the knee, you can see here this black triangle, which is the anterior bit of the meniscus. And essentially there should be exactly the same at the back. And what you can see is that's just missing. So we call that the ghost sign. And essentially the meniscus has just pinged round. So if you see that on an MRI, essentially the patient's torn their meniscal root and probably needs a root repair to reconstruct that. I wasn't going to talk too much about meniscus, but just to say there are now other things that we can do. This is a picture of me. I've cut my head off in the picture, but essentially what I'm doing here is doing a meniscal allograft transplantation, which we're doing over in Cheltenham General. And essentially the patients who've got a meniscal deficient knee, so they've lost their meniscus for whatever reason in the past, we can take an allograft meniscus, which is essentially a donor's meniscus, someone who's died and has given sort of their organs for donation. And then we can stitch that back into the knee. And the benefit of that is the patient then has a meniscus and has protective function in their knee as well. So at the moment, we've done that on about half a dozen patients in Cheltenham General. And it's mainly patients in their sort of 20s, 30s, where it's a salvage procedure, where they're too young for other surgeries such as osteotomy or even knee replacements. I was going to talk a bit about graft choice. Essentially, again, it becomes a sort of individual decision for the patient. And there's different ways of reconstructing the ACL. The 3 main ways are autograft, which is using the patient's own tissue, allograft, which is what we were just talking about for the meniscus, so using a dead person's tissue, a donor's tissue, and finally using synthetics, which are like what's used on the right here. The Lars ligament is an example. Nowadays, we don't tend to use synthetics for the ACL, as they do have a very high re-rupture rate, so the chance of it failing is very high. Allograft tends to be used in the US, but it's expensive, difficult to get in the UK. So we tend to mainly use autograft. And the 2 main ways of using it are using the hamstring tendons, so semi-T and gracilis, or using the central third of the patella tendon. So the patella tendon was sort of probably the more historical way of reconstructing the ACL. This week I've done 1 patella tendon ACL and 1 hamstring ACL. So I've probably used about 50-50 overall. The BTB gives a nice solid graft. You get two bony blocks. They heal quickly into the knee. The main problem with it is it can cause anterior knee pain, and there's a small risk of fracture as well. So if someone's in a job where they need to kneel on the knee, it's not a good idea. The hamstring is probably still more commonly used in the UK, and it's probably 60% of ACL reconstructions. It can be a little bit unpredictable, but there are ways around that. Nowadays, we tend to triple the grafts, and we're aiming for an 8mm diameter graft, which normally we can get. It tends as well to be sort of comparable in terms of its incorporation as well, but does have a slightly higher rupture rate on registry data. The quadriceps is a newer technique. I've used it twice this year. It's basically got some of the advantages of patella tendon, so it's a nice thick tendon. But the advantage really is it doesn't give the anterior knee pain. So that's being used more commonly in the UK, and will probably continue to grow as well. So I'm just going to finish off talking a little bit about lateral extra-articular tenodesis. And essentially, we're using these more and more now for ACL reconstruction. They're very old techniques, and the chap in this picture here is Prof. Haygroves. And the reason he's here is he described one of the first ACL reconstruction techniques, and he used a lateral extra-articular tenodesis, which is what you can see in the picture on the other side. And it's basically using a central third of the iliotibial band normally to act as a check brain for the knee. And Haygroves described the first ACL reconstruction in 1918, and he was professor of surgery in Bristol, so he was also fairly local as well, which is why he gets a mention. So the interest in anterolateral structures has sort of grown over the last few years. One reason is we know there's a rotational movement with the knee, and that's shown by some of the pictures I showed earlier. So clearly with the pivot, the knee sort of rotates off the back. Also, the Seagon fragment as well suggests there's damage to structures on the periphery of the knee rather than centrally. And so obviously addressing those seems logical rather than just addressing the ACL in the center of the knee. We also know as well when we test for the ACL, as I started on initially, we test that front to back movement, but also that rotation movement is tested as well. And we do that routinely with a pivot. So again, it suggests there's a rotational movement in the knee. And these techniques were commonly used. This is a literature review I performed a few years ago when I was a registrar in London. And essentially they were used widely up until the sort of 1980s. And I still see patients who've had surgery locally and have had an isolated lateral extra-articular tenodesis. But they kind of fell out of favor. And a lot of that was because techniques for reconstructing the ACL inside the knee have improved over the years. And so surgeons almost forgot about them in the sort of 1990s and 2000s. The reason they fell out of favour was obviously, as I said, advanced endoscopic technique. There was a worry about over-tightening and causing lateral compartment arthritis. Also, these techniques as well have to be done through open incisions. And although the incisions now are smaller, they're probably still in the region of sort of 6-7 centimetres. Previously, these were done in isolation, so they didn't tend to work on their own. And also as well in the past, when we were looking at these techniques, the rehabilitation was very different. And if you had an ACL reconstruction using LET, you used to be put in plaster for 6 weeks after and be non-weight bearing. So very different to what happens nowadays. Essentially, this had a focus back 10 years ago, and this is from BBC News. And essentially, we were, as groups of surgeons, looking at what was causing that Seagon fragment. This was some work published in Belgium in 2013. They managed to get onto BBC News and other channels with that. And shortly after that, I was part of a group in Imperial in London, in the Department of Mechanical Engineering, and we published our interpretation of that as well in this paper in 2014. And essentially, we dissected 40 knees, and we found a pretty consistent structure on the outside of the knee. And we think it's this structure which is probably causing the avulsion, which causes the bit of bone to come off in the Seagon area. It's probably really a blending of different structures, a thickening of the capsule, layers of the iliotibial band as well. There's also other structures in the area, the biceps and LCL as well. And essentially that work has now gone on, and there's been some big trials, including this one, which is a level 1 randomized controlled trial, which was run from Canada. And they looked at adding a lateral extra-articular tenodesis to patients where they've had hamstring ACL reconstruction at the time of surgery, and randomized between not having an LET and having an LET. And essentially, patients at high risk of failure, so those who are hypermobile in particular, and of a younger age as well, they did find statistically significant improvements in terms of graft rupture, and also in terms of measures of rotatory laxity at 2 years after surgery. So now it's becoming much more common for these techniques to be used. And I would tend to add these in for younger patients having hamstring ACL reconstruction. They do help support the knee as well. They tend not to significantly alter the immediate post-operative rehabilitation. So if you are seeing patients have an LET, really they can sort of go along the standard ACL rehabilitation regime. It's really more the meniscus that's going to change initial rehab. Okay, well, that's just about everything. So I've had a rush through and spoken and covered quite a bit about the ACL. So hopefully you're able to follow that. I never quite know when people are sat at home rather than in the room.